Fantastic. Well, again, thank you for the invitation. It's a real pleasure to give this presentation. It's a little bit sort of philosophical, and to open up questions and debate in many ways. So it will be rather brief, but that will give us more time for discussion. And I think I'd like to thank Nicos because he's done a great job of covering a lot of ground, so leaves me with very little to say in many ways. And also I'd like to say that Miles Smith sends his apologies. So he and I do a clinic together on Thursdays, but don't worry, I often tease Miles that I should have been a surgeon and he should have been an oncologist. So I think we're interchangeable in maybe in that respect. So thanks very much. So just to start off with, there are a number of options to treat metastatic or unresectable sarcomas, as Nicos mentioned. For patients with low volume disease that's asymptomatic, active surveillance or observation is a really sensible option, basically trying to leave other treatment options in reserve. And I think this is one of the messages of this presentation, is that we need to be strategic and thoughtful in terms of the way that we use treatment options. And as Nicos mentioned, select the best treatments for individual patients based on their disease and their disease profile. For some patients with multiple comorbidities and who are really unwell, sometimes best supportive care is the most appropriate treatment option. Of course, systemic chemotherapy forms the mainstay of management for many patients with metastatic sarcomas. But as Nicos mentioned, other treatments such as palliative surgery, radiation, ablation procedures such as RFA and cryotherapy, as well as embolization procedures can be used. And just to sort of reiterate the point, all of these treatment options can be used for the same patient. And in many ways, it's good, as I say, to try and keep our treatment options in reserve and trying to be as strategic as possible in terms of the way we use the treatment options available. So historically, the median overall survival for patients with metastatic disease has been in the region of about 12 months, but recent clinical trial data indicate that that's probably more in the region of about 19 months now. Again, historically, there have been limited treatment options available for patients with metastatic disease, but that's clearly improving with an increasing range of systemic therapies, but also other treatment options. And the improved survival over time is probably due to more systemic therapy options, improved supportive care, improved palliative care, better confirmation of the diagnosis, and as Nicos mentioned, multidisciplinary care. So in terms of principles of managing metastatic disease, there's clearly a lot of heterogeneity. And in terms of using systemic therapy, there's differential sensitivity, not only between different types of sarcoma, but even within a specific sarcoma subtype, for example, leiomyosarcoma. So there can be very aggressive variants of leiomyosarcoma versus very indolent variants where patients can live for a long time, for years, with metastatic disease. As I mentioned, active surveillance in terms of monitoring regularly with scans is important. So if the subtype is known to be indolent, so such as endometrial stromal sarcoma, for instance, if the volume of disease is low and the individual person has no symptoms, then active surveillance is a really good way forward. And to, as I say, keep our treatment options in reserve. For patients with solitary or a handful of metastatic areas, then local treatment modalities can be considered, as Nicos mentioned. And in terms of systemic therapy, our philosophy is often to try and keep systemic therapies in reserve and to try and maintain an individual person's quality of life. But again, these are all just principles, and we try and tailor treatment to an individual person and weigh up all of these factors with each individual person. So I think one of the questions for this presentation was, what does the oncologist think, or what is the oncologist's approach? And I think, as I say, it's important to be thoughtful in terms of the management of metastatic disease, thoughtful in terms of the number of symptoms that an individual person has, thoughtful in terms of the extent of the disease and how big and how many areas of disease there are, thoughtful in terms of how fast the disease is growing and progressing, and also factoring in the type of sarcoma. And as I say, it's important to use our treatments wisely and also strategically to try and keep as many options open for an individual person. I mentioned that chemotherapy in many ways has been the mainstay of treatment for unresectable or metastatic disease. And clearly, previously, a one-size-fits-all approach was adopted, with anthracyclines consisting of doxorubicin or ifosfamide being the two main drugs, with potentially some other drugs having activity, including dacarbazine, navalbine, and maybe platinum-based drugs. Gemcitabine plus docetaxel has now been really established as an effective salvage schedule. But of course, the FDA have approved a number of drugs over the last 5 to 10 years for sarcomas, including pazopanib, trabectedin, eribulin, tazemetostat, NTRK inhibitors. And I know that I think Dr. Trent was going to talk about the recent approvals in GIST for ripretinib and avapritinib. So there are a number of options and increasing options for patients with metastatic disease. So in terms of the aims of any systemic therapy, sometimes we use systemic therapy to try and downstage the disease. This is particularly relevant for patients that have subtypes of sarcoma that are sensitive to chemotherapy. The combination of doxorubicin and ifosfamide, although clearly a toxic schedule, does result in a higher, statistically significantly higher response rate, radiological response rate compared to doxorubicin alone. And combination chemotherapy, as I say, is toxic, and we have to factor in things like comorbid medical conditions and the general fitness of an individual person. And in terms of palliation of metastatic disease or managing symptoms, again, the chemosensitivity of a particular subtype is important, as well as the role of sequential therapy rather than using combination therapy up front. And of course, one of the major aims should be to maintain the quality of life and ensure that we're looking at the patient as a whole rather than just giving treatment for the sake of giving treatment. So this is just this busy slide. It just to almost show a point in terms of that there is a differential sensitivity to different systemic therapies, and that we should really be thinking more in terms of using different drugs for these different diseases. And clearly, doxorubicin remains the mainstay of management as first-line therapy, but we are sort of chipping away at this approach by using different agents in different types of sarcomas. Clinical trials are very important. The patient that Nicos presented that had chemo embolization for the big liver metastasis was actually on a clinical trial for about 3.5 years and did really, really well on a clinical trial. And it's good for us to be able to offer patients access to new treatments, particularly if they've got a subtype of sarcoma that's relatively resistant to conventional chemotherapy, which, as we all know, can be quite toxic. And again, it's important to obtain prospective clinical trial data in these rare diseases. And one of the fortunate things for us at the Royal Marsden is access to a very active phase 1 department led by Johan de Bono. And it's very good to have access to new drugs, particularly if there's a biological basis for a particular clinical trial. for an individual person. Of course, there are downsides, and the logistics of that can be challenging, particularly if somebody lives a long way from the hospital. Phase 1 trials often have a fairly tight schedule in terms of hospital attendance, but it's good to have the option and the availability of clinical trials. And this is a young man that we treated a number of years ago with metastatic Ewing sarcoma that had a radiological complete response to a novel agent on a phase 1 clinical trial. So again, it's trying to sort of individualize and select the best treatment for an individual person. So moving on to the role of surgery in metastatic disease, and as I say, this is more a sort of philosophical presentation in many ways, and I welcome sort of input from everybody, including Nicos, about this. And as was mentioned, the studies on resection of lung metastases are essentially all retrospective, and therefore there's an inherent selection bias that the patients that have disease that is less aggressive will be selected for surgery, and therefore those patients will have a better outcome. Very often, the previous studies have not really included control data. There's been no description of the reference population and essentially no denominator in terms of the number of patients with metastatic disease. And very often these studies have not really included information on lung function post-surgery, as well as patient-reported outcomes in terms of lung function and pain following surgery. And I think, you know, that this is again something to sort of weigh up with each individual person, that surgery for metastatic disease is not the right choice for every patient. As Nicos mentioned, it can be really helpful for individual patients, but it's important to sort of weigh that up very, very carefully. And Professor Treasure has written a lot and commented a lot about this sort of dogma almost regarding surgical resection for lung metastases in colorectal cancer, but also for sarcomas. And one of his comments is essentially for patients having sequential treatments, the patient needs to be alive to have the next treatment, which could be confused with the patient is alive because of the previous treatment. So it's difficult without randomized data to be categorical about this. As I say, surgery clearly has a role for a select group of patients, but not for everybody. And again, it will be good to discuss this in the question and answer session. And not only is there a long history of publications on the benefits of surgery in metastatic disease, but there are studies looking at surgical resection going back to the 1970s and 1980s with a more sort of critical, more skeptical view on the topic. So I think essentially, as Nicos mentioned, patient selection is absolutely critical, and it's important that we're direct with people about the evidence base, that it is retrospective, and fundamentally there are limitations to that. And you know, the question is a randomized trial feasible? I probably not. For a randomized trial, it's very important to have equipoise. And this is a slide that I often show of the Dr. Link's randomized trial of adjuvant chemotherapy in osteosarcoma. And this, of course, proved unquestionably proved the benefits of adjuvant chemotherapy for resectable osteosarcoma. And the crucial thing about this is that 36 patients accepted the randomized treatment. But notice here that 77 patients declined randomization. i.e. because of the physician's bias, they were randomized to one arm, either chemotherapy or observation, but then was swapped over and had the opposite management. There was so much bias in terms of the viewpoints of the physicians that it was almost impossible to do a randomized trial. But the analysis was the same for showed the same results for those that declined randomization, but to those that were actually randomized according to the protocol. So on a separate note, I've sort of almost presented a negative view on surgery for metastatic disease, but
sorry, Robin, you are on mute. Could you please unmute yourself again?
where did you lose me?
A couple of sentences only.
Oh, lucky you.
Sorry.
Yeah, no problem. Sorry about that. I'm not sure what happened. My computer's playing tricks with me, so let's see.
We're running out of time, Robin, so I hope you're...
But yeah, I'm nearly done.
Thank you.
Basically, so this woman in her 80s essentially had a radiation-associated high-grade pleomorphic sarcoma diagnosed in 2019. At the end of 2019, she had one small right lower lobe lung metastases. We eventually went on to resect that, but that was after a series of scans showing just very slight growth in the size of the metastasis. She's had a scan today, and everything, she continues to be disease-free. So clearly surgery has a role for some patients, but conversely, active surveillance can also have a useful role for other patients. This is a young man in his 40s with an extensive history of treatment for metastatic clear cell sarcoma, and we've been monitoring this lung metastasis for almost 2 years, well, over 2 years actually, and he's going to go for surgery over the next few months. So again, it's trying to sort of keep our options in reserve and using treatment strategically. So as Nicos mentioned, a multidisciplinary approach is really important, particularly for solitary metastatic disease. A lot of the studies that we've done at the Royal Marsden, it's basically useful to use local therapies for patients with metastatic disease that are on a effective systemic therapy as well. So radiofrequency ablation, particularly in patients with gastrointestinal stromal tumor that are benefiting from imatinib or another drug, and there's one tumor that's causing problems, so ablation can be very, very useful in that setting. And with my friend Sid Padilla, we also looked at hepatic embolization in liver sarcomas as well. We're very fortunate that Andrew Hayes does a technique called isolated limb perfusion, which can be very useful for level arm sarcomas, basically introducing chemotherapy just to that limb. And
the sound is very bad, can't hear.
oh, can you hear me now?
Can't hear you at all.
Sorry, Robin, your sound was getting very distorted. Sorry.
Yeah, sometimes the Wi-Fi, can you hear me now?
Better.
Yeah, so this is a response to this technique called isolated limb perfusion in a patient with advanced angiosarcoma. So you can see pre-ILP, the disease was very active, and then 5 years post-ILP, the disease is still controlled. So it's important, again, to have that multidisciplinary input. So in conclusion, there are a number of options for treating metastatic sarcomas. Multidisciplinary input is key. And I think the major lesson for me is that it's really important to be thoughtful and strategic in terms of using our options for metastatic disease, and as always, trying to assess and to evaluate new drugs in clinical trials is really, really important. So with that, I'll finish, if that's okay.